Hello, and welcome to the Royal College of Physicians of Edinburgh Clinical Conversations podcast. My name is Ben Warner, and I am a Respiratory Medicine Specialty Registrar in the East of Scotland, currently undertaking a PhD in Multimorbidity. Today, I am delighted to be joined again by Professor Tom Fardon, a consultant in Respiratory and General Internal Medicine at NHS Tayside, and Honorary Professor at the University of Dundee, as well as the Chair of the Scottish Severe Asthma Group within the Centre for Sustainable Delivery. We previously heard from Tom on this very podcast when we were discussing the management of acute severe asthma, who might be at risk, high risk of deterioration, ongoing inpatient management and discharge planning, and a little about the long-term management of asthma, including the concept of treatable traits. However, as we teased last time, the asthma field is constantly pushing forward. And in the UK, last year saw the publication of, for the first time, a joint guideline from the British Thoracic Society, the Scottish Intercollegiate Guidelines Network, or SIGN, and the National Institute for Health and Care Excellence, NICE, on asthma, diagnosis, monitoring, and chronic management. So 1 year on from the publication of these guidelines, it seemed only appropriate to invite Tom back on the podcast to bring us up to speed on today's asthma landscape. So without further ado, Professor Tom Fardon, welcome.
Thanks very much, Ben. Nice to be back.
It's lovely to have you back. And thanks very much for joining us. So, Tom, last time we spoke on this podcast, I think I asked you for a sneak peek of the guidelines, but as it was still out for consultation at the time, it was still very much up in the air. Now the guidelines have been published and out in the wild for a year. They've had time to percolate into practice, and hopefully they're leading to improved outcomes for patients. I wondered if we could start with you telling us a bit about what is new in these guidelines, what has changed in asthma diagnosis and care.
Yeah, it seems remarkable that it's been a year since the guidelines came out, but time does seem to move quickly the older I get. And it's been a good year for asthma because the guidelines released at the British Thoracic Society winter meeting just over a year ago really highlighted the importance of asthma, ignited enthusiasm around asthma because it gave us a lot to do. I don't think I'm understating it. I think it's the biggest change in management of asthma, certainly, since the invention of the inhaler. But I think within respiratory medicine, it's been a big change. I can't think of any other subspecialty area where there's been such a dramatic change for such a large population of people. We have to remember that asthma is by far the commonest respiratory illness. Up to 30% in some studies in Scotland, at least, have been diagnosed with a wheezing illness or asthma or have been given an inhaler at some point in their adult life. And it's higher in children. So asthma is a big deal. There's no one who doesn't know somebody who's got asthma. I think it's part of the landscape. Everybody knows that if someone's got asthma, they've got a preventer inhaler and they've got a reliever inhaler. And that might be even, you say, brown inhaler, blue inhaler, to go back really as far as the 80s and 90s, when there wasn't a lot of choice. So that's not just medics and healthcare professionals as general. The public knows brown inhaler, blue inhaler. Have you taken your preventer? Have you taken your reliever? So to move to something where there is no longer a preventer and a reliever, but there is just one single inhaler that does everything is a massive shift. And we have to think about not just introducing the changes to patients, because that's a big shift, but also to anyone who cares for or comes into contact with anyone with asthma. And that's teachers at schools, first aid people, first responders, GPs, primary care, out of hours, nurses, secondary care, urgent care at A&E, emergency departments, respiratory physicians, but anyone who comes into contact. And then some other things like prisons, for example, where there are lots of people with asthma and we need to educate people who are in prisons or people on planes, people on boats. There's a huge amount of impact. This is such a far-reaching disease. But what is the change? I'm talking a lot about the impact without talking about what it actually is. So the big change is to move away from the preventer and reliever inhaler to using a single inhaler for all of treatment of asthma. And why has it come about? We've known since the 1980s with some very compelling data that increased use of short-acting beta agonists or the reliever inhaler leads to an increased risk of death. And the data is well understood. There's data from New Zealand, from Australia, from America, from Europe, showing a clear pattern that the more canisters of salbutamol or albuterol, whichever short-acting beta agonist you use, you get through in a year, the more likely you are to die. And the converse is true with the inhaled corticosteroids. The more corticosteroid you get through in a year as prescribed, the better you'll do. But we all know that human nature is such that we don't remember to take our preventer inhaler, but we will take the reliever when we need it because it helps with symptomatic relief. So we had built for decades guidelines that say, you really ought to take your preventer inhaler, but here's your reliever inhaler, and when things get worse, take more of it. And exacerbation management was take more of your reliever inhaler, keep taking that reliever inhaler, keep going, keep going. But the more you take, the worse you do. Another powerful bit of research was the NRAD report in 2013-2014. So that's the National Report on Asthma Deaths, commissioned by Royal College of Physicians in London. And this looked at all asthma deaths across the whole of the UK and showed very clearly that the people who did unfortunately die from asthma in that period were people who had an over-reliance on their short-acting beta agonist. They underused their preventer inhaler as inhaled corticosteroid. They were undertreated in general. 50% of people didn't seek medical attention during their fatal exacerbation, and around 50% of people, their treatment did not follow guidelines. So all in all, we were not treating our patients well. We were exposing them to large doses of short-acting beta agonists, which we know was related to death. We've known that for 40 years. And the NRAD report shows that we hadn't learned from those lessons. So something had to change, and it's taken another 10 years to make that change, but that change has now happened. So there are two acronyms which we now need to get into the zeitgeist, and those are AIR and MART. AIR stands for anti-inflammatory reliever. And the anti-inflammatory bit is the inhaled corticosteroid, and the reliever is that there is a long-acting beta agonist in the form of formoterol. You have to use formoterol as a reliever because it's the only long-acting beta agonist that's very short-acting, so a quick time of action. So the aim for AIR is that you get one inhaler. Your patient gets a single inhaler, a steroid plus formoterol, and there are choices of those, and we'll perhaps talk about those choices in a little while. And that inhaler is the only inhaler the patient gets. And the instructions are very simple. Take this inhaler when you feel you have symptoms. And you don't need to take it regularly. You don't need to remember to take it when you brush your teeth in the morning, you brush your teeth at night. You just carry the inhaler around, and when you feel symptoms, you take it. And when you have more symptoms, you take more inhaler. And that means you get more steroid, and that means you do better. And this seems like such a simple idea. We wonder why we've not tried it before. But actually, the rest of the world have been doing this for quite some time. And the GINA guidelines, the Global Initiative for Asthma, have advocated this approach for many years. But we've not been able to do it in the UK, mainly because we haven't had a drug that's been licensed to do it. So we've been a bit behind. But also, I think, treatment inertia, sluggish in being willing to accept change and move on. And that often takes a guideline, and that's what's happened. So for the majority of people who have mild to moderate asthma, the decision becomes very simple. You take a single inhaler as your reliever inhaler, and when your symptoms get worse, you take more of it. And when your symptoms are fine or you're free of symptoms completely, you don't take anything.
Brilliant. And just because you just mentioned it, MART.
Yeah, absolutely. And MART has been around for some time. And anyone within respiratory medicine who's listening to this podcast will have heard of it at least. And asthma specialists are very well versed with it. It's maintenance and reliever therapy is MART. And there are a number of inhalers that are licensed to do this, but they all, again, contain formoterol because the maintenance part is easy enough, but the reliever, you have to have formoterol. So this is AIR, which is the as and when bit, but also with maintenance on top of it. So it's an easy change from AIR to MART because for AIR, you say just take this inhaler whenever you feel you need it. For MART, we say take the inhaler twice a day as well. So you've got some background treatment, and then when you need to take more, you add on top of it. So whereas AIR just fluctuates up and down from a baseline of 0, MART fluctuates up and down from a baseline of some. And I think MART has been around for, must be 10 years, maybe 15 years, certainly for a long time. And for some people, it's been very successful and it's been used, but I think there's been some reticence to move to it because of concerns about overuse of steroid or overuse of long-acting beta agonist. But the data doesn't support that. And the data that accumulated that led to the ERS consensus statement from a few years ago, the GINA guidelines, and now the NICE Sign BTS guideline, is that people who've got mild to moderate asthma who go take AIR will, on average, use 2 inhalers a year, which is not much at all. Whereas if we had them on maintenance treatment plus salbutamol, then they would get through 12 preventers plus 5 relievers. So you reduce the inhaler burden quite significantly. And on MART, so long as people take it as prescribed and suggested, then they can control their asthma much quicker, they exacerbate less frequently, you avoid oral steroids and all those complications, and you don't have massive amounts of inhaler use. So you could see that if you're on air, the asthma progresses and becomes less controlled. You can move on to MART with the same inhaler without any change to the prescription. And then once you're on MART and you're doing well, you may be able to step back down to air again with the same inhaler, same prescription. And therefore, you only need to do inhaler technique education once. You reiterate it at annual reviews, of course, but it's reinforcement of the same technique, not changing techniques. Same inhaler. I say to people, this is my inhaler. There are many like it, but this one is mine. And this is the one that I will use. This is all I need to learn, my one inhaler. And my personal view on this is I think it's a really good step forward. It really simplifies how asthma is treated. And most importantly, it aims to get us to a SABA-free future. That's a nice tagline of what we're aiming for, is to no longer use SABAs, short-acting beta agonists, because we know they're linked with increased mortality. They can be dangerous. Any asthma death is one death too many, and we should be aiming to treat an inflammatory disease with an anti-inflammatory treatment, which is what this is trying to do.
Brilliant. Thanks. That's a really nice, clear overview and shows the scale of work that there is to do, but also, as you said, it's almost a simplification or rationalization of what we're doing, actually using the most appropriate drugs for the disease, the pathology underlying it. I guess it's maybe worth just touching on, because you've mentioned this association between overuse of SABAs, beta agonists, and mortality, and then some of the reticence about formoterol being used, long-acting beta agonists being used repeatedly in MART or air. Presumably, the actual association is more driven by a reflection of poor asthma control rather than the drug itself. I appreciate there are side effects. Maybe we can touch on those from the SABAs, but someone who's using a lot of SABAs is an indicator that their asthma is poorly controlled. It's not the SABA themselves killing the patients.
You bring up a really important point because it's hard to tease those things apart. But I think it's a combination of things. For sure, people who have moderately severe asthma who don't take an anti-inflammatory treatment and rely just on a SABA are at incredibly high risk. And as you say, the SABA use is a reflection of their underuse of other appropriate treatments. There are reasons for that. Steroids don't necessarily make you feel better, not straight away, whereas a SABA you get some benefit from. And there's still some worry in some quarters from some patients about, I don't want to take a steroid because steroids are bad for me, which is frustrating for us all, of course, because we know that a small dose of inhaled steroid is hugely beneficial and saves lives. What we're trying to avoid is people getting onto oral steroids, and that's why biologics are such a win. But there are some social sides to this, or socioeconomic angles to this, that if you're in a country where people have to pay for their prescriptions, then if you have a preventer and a reliever, that's 2 prescription charges every 2 months. And then some people in a position where they can't afford to pay for both of those things, or they make a decision to only cash in the script for one or the other because of financial constraints. So if you have the choice of paying for your brown inhaler or your blue inhaler, then often people choose the blue inhaler. And that, again, as you say, reflects poor overall understanding of asthma control. There was a study done many years ago in America called the SMART study, which looked at long-acting beta agonist use because there was concern over long-acting beta agonist use. And there are differences depending on your socioeconomic background, but also on race. And it was shown very clearly that Black women, particularly, did far worse when they were given a long-acting beta agonist alone without steroid. I think this was maybe in the late 90s, and this is one of the studies which triggered trying to think, how can we combat the overuse of beta agonists generally and over-reliance on beta agonists? And if we look back at the noughties, when the landmark studies that showed that long-acting beta agonists are very effective, so like the Optima study, for example, way back in 2000, the outcome measures in those studies that showed that they were effective was FEV1, lung function, and of course a long-acting bronchodilator improves your lung function. But if you look at that data again, and the FACET study is the other landmark study, if you reanalyze the data and look at exacerbations, then patients who got more steroid had fewer exacerbations. People who got long-acting beta agonist had fewer symptoms, got better FEV1. And back in the bronchodilator era, we were very keen on FEV1, but now we're in the inflammatory era, we're more keen on exacerbations, or at least on reduction of exacerbations. So we were driven for a long time pushing long-acting beta agonists, pushing for FEV1, with less concern about exacerbations. Now we're into the era where we want to reduce exacerbations. It's not that we don't care about FEV1, of course we do, we care about lung function, but we have an understanding that the reduction in lung function is generally driven by exacerbations of inflammation, not by smooth muscle by itself. So I think that increased use of short-acting beta agonists is, as you say, is a signal. It's a signal that asthma control is not good, that the exacerbation frequency is high, because people use their short-acting beta agonists during exacerbations, and a different approach is needed when patients are rattling through huge numbers of short-acting beta agonists. Again, I think that's what's driven us towards this approach of this is one inhaler, make it simple, make sure we're treating an inflammatory process with an anti-inflammatory drug, whilst also giving symptomatic relief on top of it.
That's such a salient point, not just for asthma or even respiratory medicine, but more broadly. It's so interesting that the choice of outcome in a given trial can really change the landscape. And if you're aiming for lung function in a short-term trial, you may see improvement with bronchodilators. But if you're aiming for reducing mortality and exacerbations, as you say, you get a different result with a different drug.
That's a lesson that has taken us too long to learn. Lung function was the primary outcome in so many studies for so long. And if we sidestep into the other main airways disease of COPD, the thing we were trying to alter, thing we were trying to change, and I always turn to the ECLIPSE study because it looked very closely at what does FEV1 predict, and the only thing FEV1 predicted in that study was what your FEV1 will be the next time you measure it. And I think that, again, changed our view of what is it we're trying to do, what's the most important, impactful outcome to measure. And in asthma, it's exacerbations. Because exacerbations ultimately lead to mortality. They drive lung function decline, they drive quality of life. But critically, exacerbations are managed with oral corticosteroids. And oral corticosteroid burden is strongly associated with poor outcomes long-term and cost. So whatever we can do to reduce exacerbation frequency is going to reduce steroid burden, and therefore we're going to have better outcomes as we go on. It's not that I don't care about FEV1, and I certainly care about lung function, but it's not my primary concern now when I'm seeing people with asthma.
Perfect. So that's given a really nice context to the guidelines and motivation for them and a bit of history. We've touched a bit on the treatment, and I want to come back to that. But just before we do, the structure of the guidelines, it begins with talking a bit about the diagnosis of asthma. There's an order of tests that they now recommend. Would you be able to explain what that is? Has there been a change to that? Maybe some of the rationale behind it?
Asthma has always been difficult to diagnose, and that maybe sounds a little ridiculous for something which is so common. And I've said earlier on, 30% of people have diagnosed with some sort of wheezing illness. But there is no gold standard test for asthma. There are various different phenotypes of asthma. It presents at different ages in different ways. And trying to make a single straightforward test for asthma is impossible. The previous guidelines comprehensively gave a list of signs, symptoms, patterns that favor a diagnosis of asthma, and those which would push you away from a diagnosis of asthma gave you a high probability, a low probability, an intermediate probability, and suggested some tests, which I think was a good approach, but was complicated and required a lot of subjectivity. The new guidelines try to make this more straightforward and try to tilt us a bit more towards doing tests of inflammation earlier. So once you have a clinical history which suggests asthma, and that is wheeze, intermittent breathlessness, nocturnal symptoms, worsening symptoms with viral infections, etc., atopy, allergy, the usual things that we associate with asthma, then the suggestion is to do some tests of inflammation. So in adults, check eosinophils, do of exhaled nitric oxide of FeNO as the first line tests. My view is that this is good to do. The earlier we can do tests of what we call Th2 inflammation, so the Th2 T helper cell type 2, that the earlier we can do that, the better it is for me as a severe asthma doctor, because the sooner we will recognize people who have Th2 inflammation driving their asthma, and the sooner we can see people to offer them biologic therapy. And the most powerful measurement of that by some margin is eosinophils. Eosinophils are linked to exacerbation frequency, they're linked to decline in lung function, they're linked to symptom control. They're also strongly linked to responsiveness to treatment, which is helpful. But the eosinophil really does drive asthma in this cohort of patients. So if you've got Th2-driven asthma, the eosinophil count is really, really important. And we've been measuring eosinophils for free, effectively, for decades because it's part of your full blood count. It's one of those tests that is underneath white cells and neutrophils that perhaps no one really looks at. But I try to drill into people. It's really important to look at eosinophils and to look back historically at eosinophils. You'll know that when people come in with an asthma exacerbation, they've often been given steroids by ambulance service, out of hours GP, ED, etc. We then measure their full blood count, their eosinophils are 0. So looking historically to say, well, what was their eosinophil count when they were sick is incredibly helpful. And we will see often that eosinophils have been very high at periods in the past, then they're low when they're measured in hospital when they've had some steroids. So the eosinophil count at diagnosis is really helpful. They've not had treatment, they've not had any steroids. And what is it right now when they're feeling rubbish because they've come to see the GP? A pheno is valuable. It's easy, it's relatively cheap, and it's quick. There are machines that you can have on your desk. The test takes about, all told, probably a minute. It's 10 seconds of breathing out and 45 seconds of booting up and giving you a result. And these machines are getting cheaper, and it comes out to probably about between £5 and £10 a test. So that price will come down, but in terms of cost-benefit analysis, if you can prove that a pheno is very high at presentation, it's very strongly suggests that someone has worse asthma, and then you can titrate treatment to reduce exacerbations, etc. So an eosinophil is a simple blood test. A pheno is a test which I think we need to get into primary care everywhere so that there's access to it. And if those tests are positive, then you've nailed your diagnosis of asthma, and also you know what kind of asthma it is. And as soon as people exacerbate twice, then the Scottish Severe Asthma pathway is that at 2 exacerbations, then you should consider referral onto a severe asthma centre for consideration biologics. And if you know from the beginning, then you can get early referral onto definitive treatment. The old school tests of doing a peak flow chart and doing FEV1 and reversibility and ultimately a bronchial provocation, so a mannitol, methacholine or a histamine charge, they're still in there, but they're later on in the algorithm. And I think that reflects that, well, for peak flow charts, a positive peak flow chart, if it's done properly and the patient hasn't cheated and filled it in the waiting room beforehand, then is a very powerful thing. And it's, if you're confident the patient's done the peak flow chart well and it shows variability, diagnosis is nailed down. But a normal test, its negative predictive value is very, very poor. So always be cautious with that. I quite like peak flow charts for the right patients, but only when it's positive. Reversibility is great, again, if it's positive, but if you have 100% FEV1 before pre-bronchodilator, then it's not going anywhere. You need to see people when they're worst, not at their best. And a bronchial challenge is hard to do. Not every centre has it. Certainly no one in primary care is doing them. And even in big centres in secondary care, they're time-consuming. You have to get your patients off treatment if they're already on it. So there are challenges with that. So you have at one end simple tests, which are very powerful, and in the middle some tests which are powerful if they're positive, and at the far end things which are difficult to do. So we're not there. We don't have a gold standard test of what is asthma or what isn't, but we've certainly got tests which now help us place people into a phenotypic bucket. So we can say, do you have Th2 high asthma? This is the likely time course and this is the journey you're likely to have. But also we've got some tests in our back pocket that say, well, if it's tricky, we can always send you for a bronchial challenge test.
Brilliant. That's a great overview and absolutely nice description of how you can try and get people off the diagnostic pathway early on, or rather, onto a diagnostic label as early as possible to get them on the right treatment as early as possible. I suppose on the point of the peak flow variability, you mentioned about the right patients for it. I imagine, from my experience, occupational asthma is quite a nice setting for that if you want to see the context where things are worse.
So in occupational asthma, really the only meaningful way you can make that diagnosis is with a peak flow chart, but it has to be detailed. And that's difficult for most people to do. We need 6 weeks of data with time at work, time off work, ideally with a period of vacation or forced time away from work of at least a week. And we say to do a peak flow 6, 8, 10 times a day. Every time the patient has symptoms or takes a reliever inhaler or takes their air or MART, every time they take an inhaler, take their peak flow beforehand. And most people simply just can't do that because of their workplace that they're in, or just because it's very, very arduous to do. So again, if you get a good peak flow chart, which you can put into the Oasis machine and get the data out, that's a powerful diagnostic tool, but it can be so difficult when the data is sparse. And beyond that, doing challenge tests in an occupational asthma pathway is very difficult and requires super specialist centres.
Okay. Sticking with peak flow, among other things, I suppose having talked about diagnosis, perhaps it might be worth thinking about what we review when a patient with asthma then comes back to clinic or to their GP, or, opportunistically if they present with an asthma exacerbation. So I wondered if we could talk a bit about the kind of things that you would want to review with a patient in terms of how well controlled their asthma is, their understanding of their condition and of their treatment. What sort of questions you ask at review, what you want to cover?
So I mentioned earlier, the thing that I'm most interested in is exacerbations. So my first concern is how many exacerbations have you had? So we define exacerbations by have you had some steroids? So that can be straightforward. I can look up on the prescribing system, how many steroid courses have you had? People have at-home steroids. They get steroids through ED and through pharmacies and out of hours. So always important to delve into that to find out how many steroid courses people have had. And if people have had over 2 courses of steroids, then that pushes you towards referral onto severe asthma centres to try to think about biologics. If they're not exacerbating frequently and are not at that sort of threshold point, then symptom scores. So your ACT, asthma control test, is straightforward, simple thing to measure. We use ACQ and the Severe Asthma Service. It's 5 or 6 questions, depending whether you use ACQ5 or ACQ6, that look at symptoms in the previous week. And we know that a score of 0.75 or less is very well controlled, above 1.5 is poor, and something in the middle is kind of okay. And it takes about 5 minutes to go through the questions, but it's really valuable because you can track how patients are going. So although, because the questions are quite subjective, between patients it's not very good. You can't compare me and you, for example, because we might have a different perception of breathlessness or a different perception of what's limiting us. But within a person, it's very valuable because your perception remains the same always, so I can track how you're doing. So getting those scores done and tracking them through time is valuable, because if you've been trucking along at 0.6 for years and then suddenly it's 1.5, something has changed, and that's very valuable. And then always check inhaler technique. That's really important. Check inhaler technique at every opportunity you have to see people, because people do slip and people do the strangest things. People blow into inhalers, people do sort of double sukes, or they don't hold their breath, or they do. So it's always worth checking. And then we want to know, how is it limiting your life? How is it impacting on what you can and can't do? Have you got any other new diagnoses of things? And if people are having exacerbations, or oftentimes when people get referred on to me, the referrer will say that they're exacerbating frequently and getting chest infections. One or the other, or both. And the patient will come to me and I say, how can I help? What's the problem? And they'll say, I'm getting lots of chest infections. So what is an exacerbation? What is a chest infection? How people refer to what's going on, I think, is actually really important. Because what we don't do very well at exacerbation times, and you mentioned, if you see people ad hoc, sort of opportunistic times to see people, sometimes that's in hospital. What we don't do very well is phenotype exacerbations. We don't say what is actually going on right now. We often see someone who's got an asthma diagnosis. They come in, they're not as good, they get antibiotics, steroids, and it's called something. The patient thinks they've got a, quote, chest infection. They may have been told by someone it's a chest infection, but there's no clear evidence that they have actually got an infection and what it is. Is it bacterial? Is it viral? Is it none of those things? Is it actually an inflammatory episode versus an infective episode? So what is an exacerbation, I think, is one of my personal sort of hobby horses, and thing I really want to try to get people to dig down to is what is phenotyping those exacerbations. So when I see people for review, I say, how have you been in the last 6 months or the year? Oh, I've had 3 chest infections. And okay, what do you mean by a chest infection? What happened? Did we get an eosinophil count? Did we get a neutrophil count? CRP? Was a chest x-ray done? Did you have cough and spit, yellow sputum fevers and rigors? Or actually, were you much more wheezy? You woke up in the night, you were really tight in the chest, you were really wheezy, you just bought a new cat. We did your eosinophil count, it was 1.2, your neutrophils were normal, your CRP was normal, which is a very different story. And it's a very different pathology and a very different treatment. So I think you've got at one end the people who are on air, they're doing very well, you review them, they've not exacerbated, no steroids, you can do an ACQ and ACT, their scores are stable, their inhaler technique is great, you reinforce that they should keep taking it, and that's great. You've got the people then in the middle, they're not exacerbating, but their ACT is a bit high, they're not so well controlled, you might consider going on to MART. And then the people who are exacerbating, and you think, well, this is not so great. Can we phenotype those exacerbations? Can we look at whether it's infections or inflammation? And then early referral onto a severe asthma centre. You can follow the Scottish Severe Asthma Pathway. In England and Wales, there's the accelerating access pathway to look at instead.
Brilliant. And I think the guidelines now talk about actually not using peak flow so much for monitoring, but like you're saying, trying to phenotype what's going on. Would you use pheno? You mentioned, obviously, we often take bloods and end up by happy coincidence having a full blood count and therefore an eosinophil count when someone's unwell. But would you be using pheno, exhaled nitric oxide routinely in the monitoring, the review of patients?
So I do. I think it's really valuable. It's because it's so simple to do. It takes, can you breathe out for 10 seconds at a constant rate? As long as you can do that, then you can get a pheno and you get an immediate result. It's a bedside or desk side test. Whereas one of the challenges that's pushed back to me by primary care often is that if they're seeing a patient for 7 minutes in their clinic room on a Tuesday morning, and I'm saying to them, well, get an eosinophil count. It's well, like that will require booking into to see the phlebotomy service at some point, getting the result back 24 hours later from that, by which time 3 days has gone by and what do you do? And I completely accept that. But a pheno you could do right there and then and gives you a hard number, and if you've done it before at diagnosis, you know what the baseline is. So I increasingly do that. I think it can be very helpful. We see patients where the diagnosis is challenging. So people who have been treated for asthma for some time, or they have very bad symptoms, episodic symptoms, and asthma is high up the list of possible diagnoses, but all the tests are negative and continue to be negative. And if we can see them during exacerbation, and then we do their eosinophils and their pheno, we wait for their eosinophils, we get their pheno immediately, and it's 200. That's incredibly helpful. It's also very helpful to me to see people who I think they have a diagnosis of asthma, but their symptoms are something else, that they're not exacerbations of asthma. They have well-controlled asthma, but it's something else as well. A normal pheno at that time helps build the body of evidence that there is something else going on. And we talk quite a lot in severe asthma clinic about asthma plus syndromes, so asthma plus something else. Just because you're labeled with asthma, then it can be easy to attribute everything to asthma. But if your asthma is well controlled, you're still having symptoms, your pheno remains normal, your eosinophils remain normal, what else is it that's driving things? That, first of all, helps make us look harder. So rather than, is this asthma again, have some steroids, it makes us look harder for the extra thing. But it also helps the patient to understand that there is something else driving the symptom. So the archetype of this is ILO. So if you've got intermittent laryngeal obstruction, which we used to call vocal cord dysfunction, the symptoms can mimic asthma very closely. And by perverse fate, ILO is more common in people with asthma than it is people who don't. And when someone who has both diagnoses presents to us with breathlessness, tight chest, feeling in their throat, cough, whatever, if you can get the pheno done and it's 0 or negative, then that helps build the evidence that this is an ILO episode. The patient comes in with the same symptoms, their pheno is 150. Well, this may well be asthma. And then say to the patient afterwards, well, did you notice anything different? This was an asthma attack. The previous one was ILO. What did you feel that helps you differentiate between the two and help build that dialogue, and so we can help in the future? So I think pheno is a great tool. I think you need to be cautious because there are false negatives, false positives. But as part of the package of trying to personalized treatment for patients by phenotyping each exacerbation, I think it's really valuable. I'd love there to be more pheno machines. I think it would be great if we could get them into EDs and into our acute services and crucially into GDP practices.
Brilliant. On that, trying to personalize the treatment, I think that leads quite nicely onto our treatment algorithm that forms the next part of the guidelines. You've touched on this already. You've mentioned about AIR and MART. So briefly, could you talk us through And I think an important point to think about here, you mentioned it's such a step change, these guidelines, from what we had before. This, and the reason I mentioned about the reviews, is that this is both for people that are newly diagnosed and we're thinking, what do we start with? Where do we start in this algorithm? But also when you're reviewing an existing patient with asthma, I guess it's a chance to see how do we get them into this new paradigm of treatment and where should they fit in that?
For the new patient, new fresh diagnosis of asthma, the guidelines are very straightforward because you make an assessment of the severity of asthma. Is it mild or is it moderate? And how do you make that assessment? Well, I think you think about how did they present? Was it an insidious mild thing and they presented early? They're generally very well, but have a worsening of symptoms with a certain pollen or in certain weather conditions. And generally they're okay. You'd say that's mild asthma. If they presented to you with what in retrospect is an exacerbation and you're thinking about, oh, well, they would have had oral steroids for this, or maybe they will get oral steroids, and they have a significant deterioration in their baseline, then you might think that that's moderate disease. So for mild disease, then air, anti-inflammatory reliever, spend some time with the patient explaining what you're doing. This is my inhaler. There are many like it, but this one is mine. This is all I need to take. I just take this when I'm unwell. It's very simple to understand. That's me. If you think they have moderate asthma and you think that they will need more than just an anti-inflammatory that's straight to MART, that's a bit more of a conversation, but it's still the same thing. This is my inhaler. There are many like it. This one is mine. And I will take it twice a day, and then I will take it whenever I need it. That's fine as well. And then I think you then safety net with if you exacerbate, as in you go to see somebody somewhere in the land and you are given steroids and you get to 2 of those in a year, then you must come back and see me because there's things we can then do. We'll do some more tests and you may be referred on to a specialist. And that's important to do at the start because I don't think we do that very well and people linger out in the wild, frequently exacerbating without being referred. So I think for the new starts, that's relatively straightforward. For the person who's had asthma for some time, it's more difficult because we have a parallel system that's running, which is the old system of reliever and preventer. And running 2 systems at the same time is difficult. The analogy I always think of is when Sweden in 1967 changed which side of the road they drive on. So they used to drive on the left, as we do in the UK, and they made a decision to move to driving on the right, presumably so that when they drove into Norway or Finland, they didn't crash their cars. But they did it overnight, just one day in September in 1967. And for one day, the traffic lights were all switched around and the road signs were all switched around and people crashed into each other for a day because they didn't know what to do. But very quickly after that, they quickly moved to driving on the right. We've not done that. What we've effectively said is if you've started to learn to drive on one side of the road, but if you've been driving for some time, it's all right, you can be on the other side, but you can swap over if you like. The natural thing here is that it's going to be complicated and that people will be confused. But we're a year into the guidelines now, and actually I worry about people being confused. We're a bit overly worried about it. But what we have seen is that people are reluctant to make the switch. So what we've said is if you were driving on one side of the road, just stick to it, it'll be okay. What the guideline actually says is at review, if the patient is stable, then you can leave them alone, and that's fine. But you should consider in all people whether it's appropriate to move across to the new treatment of air or MART. So for example, if you review someone and it's evident from their dispensing prescribing data, or you just ask them, they're not taking their preventer, they're just taking their reliever, absolutely those are the people that you should move on to air. Because we know that those are high-risk people. They're not taking their steroid, they're overusing their SABA reliance, so get them switched over. So that's one group where you can really make a difference. Group 2 are those people who are underusing their ICS. So it's those people who are only prescribed a SABA, and we should absolutely not do that. The people who are overusing their SABA, and we should switch those. Then there's the people who are poorly controlled. So they're taking their inhaled steroid, they're using a lot of SABA, they're exacerbating. It's an opportunity to say, well, we could switch you to a different process here, because if we can move you on to MART, that may be all you need to change to get you better control. If that change to MART doesn't work, then we'll do some phenotyping and we'll maybe refer you on to a biologic. And it's the start of a conversation. And then at review, there are people who are exacerbating very frequently despite best efforts, and then they should be referred. So I think in my head, we have these groups of people who are prescribed a SABA only. They should definitely be changed. The people who are either only taking their SABA or they're overly reliant on it, they should definitely be changed. The people who are underusing their inhaled steroid, certainly strongly consider changing. And those people who are already effectively doing PRN treatment, so they take their inhale steroid when they feel worse and they stop taking it when they feel better, which is the human nature of just taking things when you feel bad, they would be much better off moving formally onto the air and MART rather than just sort of doing it by the back door. So certainly opportunity to make those changes, and don't be afraid to do it. People said to me, oh, well, they're fine. They're fine on their twice a day bit of preventer and then some reliever. Well, they are fine, but they might be better if you put them onto modern treatment. So I think don't be afraid to make those changes, but be prepared to have the conversation.
There's a BMJ article last year, Optimizing Inhaled Therapy for Patients with Asthma. And actually, one of the things it suggests that we do is raise expectations of asthma control. And I think, like you said, if somebody is stable on treatment, then we might leave them alone. But actually, what is stable? A patient may have lived with their condition in a fairly poor state of control for many years and expect that's as good as they are going to achieve. And actually, what we should be aiming for, well, perhaps you could share with us, what would you see as being stable? What is control of asthma? What should we be aiming for?
You bring up a really interesting but difficult topic of remission. What is remission in asthma? It's talked about much more in the severe asthma sphere and talk about biologics, because we want to think, if we've given biologic treatment, have we achieved remission? And the severe asthma community across the UK and worldwide is slowly coming together to what does remission mean. Remission is most commonly used, I think, in oncological circles, so in cancer. If you are in remission, your cancer has gone away and you're no longer at risk, you're, quote, cured. We can't cure asthma. We can control it very well, but we can't cure it. We can't take away the disease. So what does going into remission mean? So you could argue that it's not having any symptoms, having a normal peak flow FME1, being on no treatment or minimal treatment. Then you could add in your inflammatory markers. Are they low? Is your FeNO low? Is your eosinophil low? Is your ACQ less than 0.75? So that's at one end. But then is that unreachable in some of our patients? Because some of those tests, ACQ particularly, is so subjective, you may never reach that. So we've spoken about total control in the GOAL study back in 2004, I think around there, talked about achieving total control of asthma. And that was a high bar. The high bar being no symptoms, no SABA use, no nocturnal awakening, and certainly no exacerbations. And at the time, it was still, well, that's too high a bar. We can't reach that in our patients. They're always going to have something. But actually, most people can get to at least very near total control. If you take 4 out of the 5 criteria, most people can get there. And I think we have normalized steroid use in severe asthma. We've normalized symptoms in asthma. Even just in popular culture, often there's references to, oh, this kid couldn't do sport or PE at school because they had asthma. Often a sort of the wheezy kid that's a bit sickly and can't do things. And anxious people in TVs and movies puffing on inhalers. We've kind of normalized that, yeah, if you've got asthma, you're going to be sickly and wheezy and you're always going to have symptoms. So I think you're right. We need to push harder to say that if you are, as you said, stable, but that stability means 3 courses of steroids every year, that's not good enough. And those people should be referred to the severe asthma center. But stable, but I don't do any sport because it makes me wheezy, is not enough. And we should be saying, well, why can't you do that? What's the trigger for that? What can we do to help you have a healthy lifestyle? You can go for the run that you want to do or play badminton with your kids, whatever it may be. And I think that we have more options now. We have options because we have different inhaler devices, different routes of inhalers. We can try to make it so that it's not a crime, a sin to have asthma, and that because you have asthma, suddenly you can't do a whole load of different things. You should still be able to live an active life and still have a good quality of life if you've got asthma, because there's lots of options.
On these options, I appreciate we've not got limitless time, but it would be great to hear a bit more about those options of inhalers. So obviously we've talked about the sort of high-level theory of air and MART and LABA, ICS. Could you give us a very brief overview of what inhalers there actually are, what the choices are, and how you decide which inhaler to give to which patient?
In general, sort of globally, the best inhaler for the patient is the one that they can take. Whether you're talking about control of asthma, about cost, about carbon footprint and impact on the environment, the worst thing for patients is to have an exacerbation. And if because exacerbations lead to increased morbidity and ultimately mortality and worse quality of life. They're expensive to go to hospital, use out of hours, it's expensive to get steroids. So reducing exacerbations is really important. And if you don't take your inhaler, you increase your risk of exacerbations. So time spent at the beginning of the journey exploring inhaler technique so that we can get that nailed down early is the best thing for the patient. Now, having said that, if we assume that most inhalers these days are easy to use, straightforward, they all require very little in the way of inspiratory flow, and the patient is able to follow instructions, then you're left with what inhalers actually can be used for this. So we're limited a little bit by licensing, and the licensing in the UK at the moment for air are 3 inhalers, and they're all formoterol-containing inhalers because they have to have formoterol in them. And they are Symbicort, which is budesonide plus formoterol, in its turbohaler form, which will be familiar to most people who are listening to this podcast, I'm sure, been around since the early 90s. There's an inhaler called Walk Air, which is probably not well known to people, but is the same contents as Symbicort, but in a different inhaler device. And then the Spiromax Duo Resp, which is an inhaler which looks like an MDI, but is actually a DPI. So all 3 of these inhalers are dry powder inhalers. There isn't a metered dose inhaler, old school, as it were, push and squish sort of inhaler. They're all dry powder inhalers. So they all require a more forceful inhalation rather than a slow and steady inhalation because there's no propellant. You need to drive the inhalation with your own inspiratory flow and then a deep breath hold at the end of it. Each individual health board or down south, the trusts will make their own formulary decisions about which of these inhalers to use. But the choice is familiarity with the inhaler, cost of it obviously important, and evidence base, most of which the research was done with Symbicort in the build-up to the licensing and the change of guidelines. And Symbicort's very familiar to people. You need to spend some time explaining what the inhaler is, how it works, what you do with it. And of course, if the patient is unable to use a dry powder inhaler for whatever reason, then you have to move to other inhalers with other propellants, an MDI and a spacer, which then at the moment, there's no license indication for those. I was at the British Thoracic Society meeting last month. I chaired a session on inhalers, and there were a number of studies that were presented using the air process with other inhalers. So with beclomethasone and formoterol, for example. So the treatments like Foster or Lufabec, so rather than budesonide, it's beclomethasone. And of course, the evidence was these treatments worked very well. There was non-inferiority to budesonide and the same sorts of results. So it's my suspicion that the licenses will extend and that we'll have a lot more choice. There's no rationale why you wouldn't work with beclomethasone rather than budesonide. I don't think anyone would argue that budesonide has anything special in it that's any different from beclomethasone in this context. And the BTS Sign Nice guideline does say use the licensed drugs, but you may wish to consider other drugs that contain formoterol. So I think it's up to local health boards, local formularies, trust down south to have these discussions and to make sensible, realistic medicine type decisions about what inhalers you can use. But at the moment, the license indication is limited to those 3 choices. My experience has been that the vast majority of people are absolutely fine with a dry powder inhaler, and that we've had very, very few people who we've had to move back to an MDI with a propellant because the DPIs are so straightforward to use.
Excellent. That's really helpful just to remind us that the inhalers are both a device and the combination of drugs within it. So as you said, the dry powder inhalers and the pressured metered dose inhalers driven by a propellant. You mentioned the dry powder inhalers, you need to take a sharp breath in. So obviously somebody needs to have the capability to do that. But conversely, I guess the metered dose inhalers are maybe historically what people picture when they think of asthma, as you said, someone puffing away on it. But actually, it's not all that simple, is it? I mean, you need some coordination to get that down into your lungs and not just hit the back of your throat.
Yeah, and this is what the irony of things is that we've been using MDIs for a long time, and it is in the public eye of, what is a push and squish type of inhaler, the pressurized metered dose inhaler. But it does require quite a lot of coordination of initiating the breath, the inhalation, pressing at the right time, continuing in a slower, steadier inhalation. And if you use a spacer, then that is made a lot easier, but then you need to carry a spacer around as an extra bit of kit, which a lot of people don't like carrying around with them. And we know that the evidence is that the older you get, or the less likely you are to be able to use an MDI inhaler properly. Yet in the UK, we're really married to MDI use. And I'm sure that many who are listening will be well aware of the comparison to the Nordic countries, where well over 80% of inhaler use is DPI, less than 20% is MDI, and where the other way round, in the UK, over 80% is MDI. Yet they have no worse outcomes than we do. In some regards, they have better outcomes than we do. And there's a very clear carbon footprint benefit to using DPIs than there is MDIs. And in the asthma community and the COPD community, we've been, I think, for years now trying, albeit slowly, but we have been trying to push towards using DPIs rather than MDIs, and also to push the manufacturers' MDIs to make them easier to use, better propellants, lower carbon footprint, really push that along. And that has started to happen. But you can be more confident if you pick a DPI as your first line inhaler that it's going to be easy to use, it's going to be a good carbon footprint or better than other inhalers, and it's going to be reliable, and most people will be able to use it with good outcomes.
I think that's so important that people do understand the benefits and the rationale for those different devices, because, as you say, I think it is increasingly entering the consciousness of clinicians that there is a carbon footprint to what they're doing. And, 13% of the NHS's carbon footprint related to delivery of care is from inhalers. And that is massively driven by these MDIs. But that's not the only reason. In fact, it's not the most important reason for the decision around what you give a patient. There are all these other benefits to DPIs in certain contexts. And as you say, even not all MDIs are created equally. There are some that have much worse greenhouse gases within them than others. And ultimately, absolutely, an inhaler that gets used within a couple of weeks and then needs another prescription is much worse than 2 inhalers in a year that are used well, whatever the inhaler is. There is a really nice website, Greener Practice, which I'll put a link in the description, about the carbon footprint of inhalers and how we can improve our prescribing. But a lot of it is around actually having a discussion with patients about how to best control their asthma.
Yeah, absolutely.
So you've given a really clear overview of a lot of the inhalers that we might use. I think just very briefly, I know LAMAs and leukotriene receptor agonists, they're still in the guidelines, but as a sort of give it a try. And importantly, if it's not making a difference, stop it. But you said again and again, if somebody is needing repeated steroids, we should be referring to specialists for specialist interventions. And predominantly nowadays, that means biologics. So it's a massive topic. It's a huge field. You've got maybe 2 or 3 minutes. Perhaps you could just give us a very brief overview of what biologics are, which ones there are, broadly what they're targeting, and who you use them for.
Yeah, so obviously biologics are my favorite topic and we could spend another hour, but I'll try and be brief. First thing, just important, you mentioned about LAMAs and leukotriene receptor antagonists and all those other things. They are still in the guideline, but they're in a box below the point of referral onto biologics. And if at the point in the guideline where people have exacerbated more than twice, poorly controlled asthma, measure Th2 markers, so an eosinophil count and FeNO, and if they're high, then straight to a severe asthma centre for biologics. If they're low, so we think it's not Th2 asthma, there's no Th2 signal, then go on to give LAMAs and to give leukotriene receptor antagonists, etc., as you've described. Trial, stop if don't work, and then consider referral. So the point is that if there's a Th2 signal, then the evidence is very strong to use biologics rather than playing around with other things. So that's an important message. So what happens when you get referred on to severe asthma centre? What we're looking for is trying to find patients who've got a strong Th2 signal, and therefore we know that eosinophil-driven inflammation is what's causing their exacerbations. And those are the people we want to find out about early, because we know early intervention improves outcome dramatically. The license indication for biologic is for people who've had 3 or 4 exacerbations in the previous 12 months, depends on which biologic. But in Scotland, when we looked at this in 2024, the mean number of steroid courses in the year prior to initiating biologic was 7. So people were waiting a long time before we think about referring for biologics. So we can refer much earlier and we can treat much earlier. The biologics are all centered around Th2 inflammation. The aim is to reduce eosinophil proliferation, maturation, and migration into the lung tissue, because eosinophils are increasingly convinced they're not just a marker, they're not just like FeNO, a marker of their big inflammation. They are the effector cell that is causing the damage. They degranulate and produce lots of toxic materials which cause damage. They make extracellular traps, which are DNA-rich secretions, which we knew came from neutrophils, but we now know come from eosinophils as well. They increase mucus production. They lead to Charcot-Leyden crystals and mucus plugging. We think that they are a really important cell in the middle of asthma. The biologic treatments are targeted at IL-5, which is a very potent driver of eosinophil activity, IL-13 and IL-4, which, as well as driving eosinophil activity, are involved in IgE production and class switching of IgG to IgE. And the most modern of the biologics is anti-TSLP. TSLP is an alarmin. So alarmins are the IL-33, IL-25, and TSLP. They are the signals that are triggered by the epithelium. And we'd think it doesn't really matter what the trigger at the epithelium is. The alarmins are released in response to epithelial trauma. They then start the cascade, which then leads to increased ultimately IL-5 production and IL-13, IL-4, and then the eosinophil activation, mast cells, IgE, etc. So we can act to suppress eosinophil function and activation by giving biologics early. The choice of what we give depends on a number of things, and there's a little black box of what happens in severe asthma, MDT. But ultimately, we need to see the patients early who have a Th2 signal so that we can then put them through the process of evaluation, phenotyping, and come up with the best biologic for them as early as possible. And they work. They really work. It's one of the most rewarding things about doing severe asthma clinic is that patients come in for assessment and they're miserable. They're getting up to, on average, 7 courses of steroids in a year. Their quality of life is terrible. Their side effects from the steroids are high. And they've spent years like this, years and years and years. We put them through the process. They get a biologic. They come back 3 or 4 months after initiation, and they are delighted. I said, well, I couldn't believe that this is what everyone else feels like. I've not had any steroids. I've not touched my blue inhaler, they often say. And they're asking, can I reduce other treatment? This is amazing. So for the right patient who has eosinophil-driven disease, and we can measure that, for the right patient, you can literally transform lives. Doesn't work for everyone, and sometimes it's second-line, third-line treatment. But as we've been doing this for the last 5 or 6 years, I think we increasingly have the confidence that we can pick the patients who are going to benefit, and they really do benefit. It's phenomenal how the improvements in quality of life we see with some people.
Fantastic. And these are monoclonal antibodies. They're targeting part of your immune system. But I know we think of other drugs in the same sort of category as being quite, you treat them tentatively or cautiously. But eosinophils, evolutionarily, they're your response to helminths and parasites, which happily we have less exposure to, at least in the UK now. Are there concerns about patients' exposure to infection, or can we just say the side effects are pretty minimal from these, really?
I, like you, was taught that eosinophils were evolutionary. They're there to treat helminthic infections and to stop us getting worms. So when the IL-5 monoclonal antibodies, particularly benralizumab, which is very, very potent at suppressing eosinophils, you could almost go as far as say that they eradicate eosinophils, that though people will be at high risk of those infections, but that signal just simply isn't there. So that trials have been carried out in South America and in Africa, where there is a much higher incidence of helminthic infections, and there is no signal for those infections. If you look in the BNF, it will say that these drugs have a side effect of increased infections, but that doesn't bear out in clinical trials. And in the severe asthma community, it's not something we worry about at all. The side effects of the drugs are generally mild, they're generally short-lived. Injection site irritation, headache, which can sometimes last a few hours after the injection, sometimes abdominal pain, again, which is short-lived. There's an unusual incidence in some people of hair loss, but you can generally detect that quite early and switch to a different biologic. Dupilumab has been associated with some eye complications. Again, this is usually in people who already have eye issues, and we have alternatives. And tezepelumab, which is the anti-TSLP biologic, has around a perhaps 10% incidence of arthralgia. So apart from that, and we consent all our patients to understand these risks, the risk-benefit ratio is very strongly in favor of these drugs. Other biologics, other monoclonal antibodies that are immune suppressants, we mustn't conflate the asthma drugs with those drugs. So TNF-alpha blockers, adalimumab, etanercept, infliximab, anakera, IL-1 suppression, They are different ball game, and they're hugely immunosuppressive and a hugely increased risk of developing bacterial infections. These are not they. So I get asked frequently by concerned anaesthetists preoperatively, or surgeons or dentists as they're about to take some teeth out, when should we stop the biologic? How long will we stop it before an operation? This patient has got an infection of the something. How do we reverse the biologic? And that's not the case for these. And I think it's important to get that message out. Locally, we've done that, is that the asthma biologics should continue regardless. They don't suppress anything apart from Th2 inflammation. Eosinophil suppression does not lead to an increased risk of bacterial infection, viral, fungal, helminthic, worms, anything. And that it's important to continue these drugs preoperatively, because the last thing the anaesthetist wants is loss of asthma control whilst doing an anaesthetic. So we tell the patients this. We give them information leaflets to say, if you have an operation, you should carry on. If the anaesthetist asks a question, tell them to phone me and we can have a conversation. You cannot say any drug is 100% safe. Of course you can't. But I think that there are minimal side effects. And in the 7 years of clinical practice with monoclonal antibodies across the world, no serious side effect signal or adverse event signal has been identified as yet. And in that regard, I'm very reassured that they are a safe approach to asthma treatment. And what I can say fairly definitively is that they are much safer than repeated courses of oral steroids.
And I guess you mentioned about perioperatively and so on. I suppose the other big situation people worry about is in pregnancy. But again, as you said, oral steroids and asthma exacerbations, these things are very well-known risks.
And the BTS sign guidelines from 2024 did not broach this. And the sign guideline from 2019 has a section on pregnancy. But because the evidence base is so sparse, because there are no studies done in people who are pregnant, the advice, the mantra, I suppose, is that the best thing you can do for both the mother and the baby is to keep the mother as well as possible. And that, for us, has been patients who are stable on a biologic, or in remission, you might even say, on a biologic, should remain on a biologic. There have been some cases of people stopping their biologic in pregnancy and then exacerbating and end up in ICU whilst pregnant. And this is obviously an incredibly high-risk situation. There are worldwide many people who have gone through pregnancy on biologics, and there is no signal. We haven't had any reports of adverse outcomes in pregnancy. So in the same way that we continue all treatments that are keeping the patient stable during pregnancy, that includes biologics as well. This obviously needs to be discussed on a case-by-case basis with each patient and the clinician. Certainly my experience has been to continue biologics through pregnancy.
Brilliant. I think there's such a great example of really targeted precision medicine and personalized medicine. And he said, although there is a sort of black box of the asthma MDT, a lot of it is about getting the right medication for the right patient. And that's not something you can really put in a flowchart or an algorithm. You need to consider them holistically.
Yes, and if you do look at the Scottish Severe Asthma pathway, much of it is flowcharted, but the bit when you get to asthma MDT, we just simply can't flowchart that. There are considerations. And those considerations at the top of the list is patient-centeredness and realistic medicine. So they are dose frequency. Can people take it every 2 weeks, every 4 weeks, or every 8? So there's some degree of patient preference in that. Phenotyping, genotyping. There's a lot of things to think about and trying to personalize those things to each individual. It's not just a first line, second line, third line. If only it were as easy as that. It takes time to consider each individual patient. But it's very rewarding because, as I say, people come back to clinic in tears, happy tears, about how much it's changed their life.
That's wonderful. I have one very last question, because it's a real bugbear of mine. You've mentioned tezepelumab, dupilumab, benralizumab. These are impossible names to say. Why are they all called that? There is a rationale, isn't there?
Yeah, there's a naming convention for all monoclonal antibodies. I sometimes think I should look this up and work out what's going on. All of the monoclonal antibodies have a naming convention that's based on what they're targeting. So I'm afraid we're kind of stuck with benralizumab, mepolizumab, dupilumab, and tezepelumab for now. And in the next year or so, we've got another one. It's called depakimumab. So it's something to add to the tongue twisters of asthma biologics, I'm afraid. We are stuck with it.
Wonderful. Well, we've got to earn our keep somehow, at least by learning the language. Tom, thank you so much. That was another tour de force of asthma, from point of diagnosis through to specialist care. I really appreciate your time and picking apart those new guidelines, which I really hope we will see the benefits at an outcome patient and population level in the years to come. Any final thoughts, any last pearls of wisdom you wish to share before we wrap up?
Thanks for inviting me back, Ben. It's always a pleasure to chat about asthma. I just encourage people to have a look at the guidelines. It's a lengthy document, but the flowcharts are really helpful. There are some summaries you can read, the headlines. And when you see someone with asthma, whether it's because they're presenting fresh, brand new, whether they're presenting because they're exacerbating or a problem, or you're just seeing them coincidentally, have some thought about those guidelines and what's the best for the patient. It's not what we learnt at medical school or nursing school or pharmacy school. It's not what we learnt. It's changed. It's changed a lot, changed for the better. And I think a bit of time spent with the patient explaining why we've changed, why it will benefit them in the long run, I think is time well spent. It is also helpful, I think, to signpost people to the plain language version of the guidelines, which is now available on the SIGN website. So if you just search for SIGN plain language asthma guideline, or I'll perhaps send you the link, Ben, so you can put it into the description of this podcast, then there is what it says on the tin, a plain language version of the guideline to explain to patients in simple terms what that guideline is and how we treat asthma these days. It's not yet on the Right Decision Service, but it will be. So I would encourage people to have a look at that. And if you think your patient has severe asthma, they probably do, and think about referring on to a severe asthma centre, we're really keen to see these patients.
Fantastic. Thank you so much. I will put that link in the description along with the guidelines and all the other topics we've covered. So that just remains for me to say thank you once again. Really appreciated your time and your insights, Tom, and I hope we can get you back on the podcast at some point in the future.
Thanks very much.